Dr. Gitanjali is going to present us with vitreopapillary traction, a missed or underdiagnosed entity.
Good afternoon everyone. I'll be discussing about two cases of vitreopapillary traction, which is an often missed or underdiagnosed entity. So the first case is a 50-year-old female who came for second opinion regarding her optic disc edema. She had already undergone MRI, visual field and neurological examination before coming to us, which were all normal. She did not have any history of headache. Her best corrected visual acuity was 6/6. Other anterior segment examination was normal. So coming to the fundus photograph, what we see is a bilateral blurring of the disc margins. But the other entity is we can see a epipapillary membrane that is present over the disc in the right eye and a faint membrane in the left eye also. So we did a OCT scan, and the raster scan revealed the presence of bilateral hyperreflective membrane as shown by this white arrow, which is present over the disc and causing traction in both the eyes. Why it is not true disc edema? Because there is absence of clear space underneath the nerve fiber layer, and there is no bowing of the RP as we can see here. So in the absence of any underlying organic pathology, a diagnosis of vitreopapillary traction was made, and patient was followed up over 1 year with stable vision and no progression of traction and edema of the optic disc, and no visual field defect was developed. The second case is a 60-year-old female who developed diminution of vision in right eye for past 3 months. She came with the best corrected visual acuity of 6/12 and left 6/6. Anterior segment evaluation was, there was bilateral nuclear sclerosis, right more than left. Other things were all normal, color vision, visual fields. So dilated fundus examination before surgery, we noted bilateral blurring of the disc margin in the left eye. There was sparing of the temporal disc margin, but the surrounding vessel architecture is all normal and there are no macular changes. So we did an OCT scan. So what we see here is an posterior vitreous detachment that is still attached at the disc, and more so at the nasal margin, causing traction of the nasal margins in both the eyes. In this, the PVD has been induced temporally, but here the vitreous is adherent, but only on the disc it is causing traction. So a diagnosis of vitreopapillary traction syndrome was made in this patient also, and she underwent cataract surgery, and on follow-up she recovered good vision. So what is vitreopapillary traction? It is a syndrome used to describe the traction caused by abnormal vitreous condensation at the optic nerve head during the evolution of the posterior vitreous detachment, and the similar condition can also arise due to presence of abnormal glial tissue at the optic disc. So the etiology is idiopathic due to PVD, or secondary due to proliferative diabetic retinopathy, or vascular occlusions, or epiretinal membrane, or AION. The histopathology reveals vitreous fibrils meshed with glial cells, fibrocytes, astrocytes, RP cells, and myofibroblasts. The clinical features can be either peripapillary or disc hemorrhage, subretinal hemorrhage, blurring of the disc margins. Mostly it is a unilateral entity, really it can be bilateral. The symptomatology ranges from asymptomatic cases on long-term follow-up to diminution of vision and field loss, mostly noted in cases of secondary VPT, that is due to exoplasmic stasis. The field loss in VPT and vision loss were documented to be reversible after surgery. So the management in asymptomatic cases is a follow-up of these patients with OCT and vision and visual field evaluation, and symptomatic cases need surgical management with pars plana vitrectomy, PVD induction, and peeling of the residual membranes. So to conclude, a relatively uncommon entity with benign nature should always be kept in mind by ophthalmologists when we are dealing with the patients of unilateral or bilateral disc edema, as ruling out by simple OCT scan can prevent us subjecting the patient to unnecessarily investigations. Thank you.
What is the mechanism of vision defect in this condition?
So it has been noted due to because the membrane is pulling off at the nerve fiber layer, so it leads to exoplasmic stasis. So that is causing that.
So what kind of visual defect you see?
Yes, sir?
What kind of visual defect?
It is like central scotomas or the enlargement of the blind spot.
The patient is symptomatic with this?
In our patients are asymptomatic. I read the literature, but there were field very central.
So it's an incidental finding basically.
Yeah. So
it's a known entity.
It is a known entity, like vitreomacular traction. It is less frequently known and diagnosed, but it is a known entity.
So you wanted to just highlight that.
Yes.